Welcome to our webinar, Caregivers, What to Expect When a Loved One is Diagnosed. Thank you for joining us. I'm Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors, Amogen, Alexion, Apellis, Merck, and Taiho Oncology, and the generous support of our patients, families, and caregivers, who without your support, this webinar would not be possible today. I'd like to let you know about a few opportunities for caregivers and patients to be able to connect. We do offer monthly virtual support groups. Our support groups are all volunteer-led by caregivers such as yourself and also by patients. All of the support groups are listed on our website. What you would need to do is just register for the group of your choice. And then once you're registered, you do receive an email confirmation with the login information for you to be able to join the group. Each of the groups are listed monthly, and you can find the groups on our website, which is aamds.org. Now let's go ahead and get started with information about the webinar. So immediately following the presentation, there will be a question and answer session. You can submit your question or a comment using the Q&A icon in the bottom of your screen. Just open the Q&A text box window, type in your question or comment, and when you finish typing, just hit enter. We'll be sure to try to do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming question. Submit your question all at the same time. And second, please do not share private health information in your question. Our expert today cannot answer any specific questions related to your health care. Our expert today is Swapna Thota. Dr. Thota is an associate professor at the College of Medicine in Memphis at the University of Tennessee Health Science Center. Her clinical practice focuses on bone marrow failure states, including patients diagnosed with aplastic anemia, acute leukemia, myelodysplastic syndrome, myeloproliferative neoplasms. She's a clinical researcher interested in diversity, inclusion, and access to care for all patients, as well as translational research in myeloid malignancies. It's my extreme pleasure to welcome Dr. Thota today.
Thank you for that kind introduction. I really appreciate the opportunity to be together with a lot of families that are going through bone marrow failure and what really to expect when your loved one is diagnosed with bone marrow failure. I really enjoy taking care of patients with blood diseases and blood disorders, and I take every opportunity to help, to offer a helping hand to kind of explain the diseases, because it could be intense. Blood cancers are not common, blood disorders are not common, and you would not typically come across a patient that has your diagnosis. So I really appreciate the opportunity to be with you all today. It's a beautiful day in Memphis. So let's get started. Bone marrow failure, various blood cancers and blood disorders, benign and malignant, present with bone marrow failure. You would have had friends who have suffered from breast cancer, prostate cancer, heart failure, or kidney failure. These are the common things that you would see people suffering from or hearing, and have a concept of what that journey might look like. It is rather rare, like I had mentioned before, that if you didn't seek out, you would have walked into somebody with a similar diagnosis like yours. So today we will spend some time trying to understand, what does bone marrow do? What happens if you do not have an adequate bone marrow function? How do you diagnose bone marrow failure? Why does one develop bone marrow failure to begin with? And what do you have to do once you have bone marrow failure? To have an understanding of the bone marrow failure, let's just understand what bone marrow does. blood that we all have inside our body is made in a factories called bone marrow. Bone marrow is filled with stem cells. I've put two pictures here of what a bone marrow looks like. The top picture is less magnified. So under your skin and muscle is your cartilage and bone. Inside the bone is like a fluid and spongy tissue called bone marrow. Here you see trabeculae. Bone marrow it's very strong on the outside and gets a little bit hollow while you go inside the bone, and it's filled up with the spongy tissue. If you magnify some of this pink tissue that you'll see pink and bluish tissue, which are filled with stem cells. These stem cells are capable, as it sounds, the name refers to, can replicate slowly. They multiply very slowly and make more of their own cells and give rise to the mature blood cells that we all carry and that circulate in our blood. We approximately, most adults, hold up to anywhere from 5 to 6 pounds of stem cells or the density of bone marrow within our body. So the holes that you appreciate here is what is referred to as a yellow bone marrow. It's filled with fatty tissue, and the pink and the bluish part is what is referred as the red bone marrow, which is what gives rise to our blood each day. In our body, it is a continuously working system, just like our hair grows every day, different parts like our nails grow every day. Stem cells, they divide to make baby cells to give us blood that's made every day. So what is inside our blood? Blood consists of many different things. It consists of a lot of unique different cells. When you and your family member go to a doctor and you're interested to know your blood counts, what they do is take a blood sample from you, drop a tiny bit of, if you take a tiny drop of it, drop it on a slide, stain it, and look under a microscope. This is how all of our blood cells look like. We have red cells inside us that carry oxygen around and give us energy. If you're low on red cells, you're called anemic. You might have heard of that terminology before. There are two types of white blood cells that I'm representing here. One refers to a granulocytes. If you pay attention, there's tiny bluish granules here, and there is the DNA or the nucleus of it. This is our primary defense. When we get pneumonia or any infection, these are the cells that protect us and are the first line of defense in our immune system. This is called the lymphocyte. It protects us from viruses. When we take vaccines, these are the cells that see the vaccine and protect us from a future virus. Then besides the blood cells, we also have a liquid portion of our blood called plasma. Plasma is mostly water, but it also contains important proteins, sugars, hormones, and are critical to keep us alive. So they all exist in harmony, making our whole blood. Let's talk a little bit more about red blood cells, white blood cells, and platelets, because this is probably what you heard of while you were being diagnosed or your loved one is being diagnosed of a bone marrow failure. How does bone marrow failure feel like for a person? You would have heard the term pancytopenia. If all the blood cell lines are on the lower end, the medical term for it is called pancytopenia, pan being all, cyto, cells, penia are low. So bone marrow failure is a scientific term or a medical term, and pancytopenia is literally the symptom of it, like pneumonia and a fever, that kind of correlation. A person that has it has some vague symptoms like being tired more than usual, because tired is a regular symptom. It's more sleeping and resting longer. Some weight loss that you might notice. If it is of cancerous origin, you might have some bony pains. In certain disorders, because liver and spleen belong to our bone marrow system, and if they're enlarged, you may have some abdominal pain or discomfort as well. So there are some systemic symptoms that you could perceive and identify is something going on with my blood or blood work. If your reds are on the low side, you will hear the term anemia that your doctor will mention, which means your values and your blood counts, your hemoglobin will be on the lower side. Any value less than 12.5 in men and 11.5 in women is considered lower limit of normal. Below it, you're considered anemic. fatigue, weakness. It'll be very obvious if you get anemic. People feel winded walking. You get really tired. So this is the main symptom. A lot of people with anemia tend to go to doctor for. Anemia can be of several different reasons. Women that have menstrual cycles, bleed heavily, could be anemic from iron deficiency. So there are different causes for us, nutritional illnesses and things like that. But how do we identify anemia? Is mostly from a bone marrow failure. We count something called reticulocyte, which is the baby red cell count. If that's on the low side, that's one of the things your blood doctor is thinking of, oh, this anemia looks a little bit different. The red cells look larger than they should, and the reticulocyte count, which is the baby red cell count, is not keeping up with the anemia. If it's because there's a particular bone marrow failure condition where you're actually making blood, but your body breaks it open, this phenomenon is called hemolysis. And when that happens in your body, it leads to anemia. And you may also notice at the same time, because the red cells are breaking open and releasing hemoglobin into your blood, and it comes out as dark urine. So that's one of the signs of bone marrow failure causing anemia and hemolysis. Platelets, these are tiny cells. In the last slide, if I had shown, there are these tiny dots in the smear that we looked at. Those are the tiniest cells, but the mightiest cells. When you have low platelets, you would hear the term thrombocytopenia. Thrombocytes are the mother cells that make platelets. So bleeding, bruising, petechiae are some of the symptoms that you will see if you have less number of platelets. Platelets help in clotting. But if you have not enough cells, you tend to bleed or bruise or have petechiae because of it. That's one of the symptoms that makes you concerned what's going on with my blood work again. Low white blood cell, typically in a medical term, we would call that neutropenia or lymphopenia. When your immune system is low, it is natural. One comes down with like a bacteria or viral infection. If you don't have infection, but you're having frequent aphthous ulcers, that's another sign that your immune system may be on the lower end. So these are some of the spectrum of symptoms that your family member might be feeling, something that could hint that there's some abnormality going on with your bone marrow or your blood work. When you go to a doctor, the first thing in business that they will do is they do a lot of blood work. There is no way to diagnose a blood disorder. It sounds very paradoxical. You come in anemic and your doctor is doing a lot of blood work, but there's no way to look at a person and tell what's going on without doing blood work. So you'll do a lot of tubes of blood work on your initial visit, where they try and make sure your low blood counts are not really because of iron deficiency or B12 deficiency or an infection hiding or a medication that you got recently started on that it could impact your blood cell or any other immune problem that might be happening. So sometimes the story is very telling. So your doctor listens to what's been happening, when did this low blood count start, how long this has been going on, how are you perceiving it? So history taking is critical. On top of that, they will start to do with some of the blood work. Once all of the different causes for the low blood work have been ruled out, the next step in the process to actually identify what specific type of bone marrow failure your family member has, they do a procedure called bone marrow biopsy. Here in the slide, I have demonstrated a child undergoing a bone marrow biopsy as well as an adult. The two common spots doctors might go after is either sternum, because all our long bones have bone marrow inside it, but a most common spot is what's called the posterior iliac spine on the hip bone. So you're either laying on your side or on your belly, your skin is numb up, your doctor talks to you in detail. Most of the time in adults, you're conscious while doing this procedure, so you're still able to interact. It's they numb up the skin and bones with lidocaine. I describe to a lot of my patients this procedure. There's a lot of panic around the procedure. If there is severe anxiety, I give some anxiolytics and things like that to get through the procedure. Children typically get general anesthesia for this procedure so they can lay still. If you had ever had tooth pulled, it's a jawbone that the tooth will get pulled out of. The feeling, the numbness that you feel during the procedure is very similar to a bone marrow biopsy, because we are going to a bone that's on your back. You're typically laying on your side or on your belly so the doctor can access the bone easily. It is dependent on the person performing and the type of anesthesia. In an experienced person, it shouldn't hurt more than in the initial part where you get numbing medication. That should be the worst part of the bone marrow biopsy. So you may or may not have to undergo this procedure to be diagnosed as with bone marrow failure condition. Once they do bone marrow tests and blood tests to identify exact type of bone marrow failure, because there are different kinds of bone marrow failure conditions, your doctor, before they meet you again to give you the results, they're into a lab doctor who's looking at the blood cells under a microscope, looking at how these cells look, just like the one I had showed you before about your peripheral blood. And they're extracting DNA out of those cells, and they're doing genetic tests on those cells. So sometimes some of these specialized testing may take a few weeks to perform the whole testing and resulting. And then a lab doctor puts everything together to give you a diagnosis. Some of the bone marrow failure conditions like aplastic anemia, it's not like you send out a test and it comes back as positive to give you such a diagnosis. There are no specific diagnostic testing like that. So it takes an experienced blood doctor and an experienced pathologist to sit together to make sure this doesn't feel like any other disorder, and then to call it aplastic anemia. So clinical diagnosis really takes a team effort. So collaborative care is key to success, and that's something you need to look for when you go to a doctor. Are they working with a good team? Are they do they have a good experienced pathologist? Because a lot of these things is experience. Is the cell looking normal or abnormal? So that's one of the questions you could ask your doctor while making sure the diagnosis is accurate. So when you're going to a doctor, and it's not just the doctor, it's a whole team that's working for you. So who should be on your side? What does your care team look like? Ideally, there's a primary care doctor who takes care of your regular checkups, your blood pressure, or whatever is going on, your overall health. With the hematologist, usually in most academic centers, there's either a trainee, a resident, or a fellow, or an advanced provider, nurse practitioner, physician assistant that helps them take care of you. And the hematologist, who is your blood doctor specialist, who is aided in multiple decisions by a pharmacist, and your spouse or your caregiver or your child or your friend. And their support is a key member to all of this care that is being provided to you. Case managers that help you through financial roadblocks. The reality of falling ill is taking care of our bills too. So you have to make sure you know who to contact once you see the doctor for all the visit. If you do not have an insurance, how can they help you enroll into an insurance, and so on and so forth. Some other bone marrow failure conditions have an inherited pattern. So there is a geneticist that does testing and talks to you about it in most academic centers or most places where they take care of bone marrow failure conditions. And like I talked about, the experienced pathologist who looks at the cells and talks to a lot of people about the blood work and specialized testing that are being sent are also critical part of the team. It's just that you don't typically have an interface to them directly. It's your doctor that's the mediator between you and the lab doctor. So I've been telling a lot about what bone marrow failure feels like, what tests might be done, how you may be diagnosed. What does the diagnosis looks like? There's several different conditions, like I'd mentioned early on, that present with bone marrow failure. They can be put in two different boxes. One is you were not born with it, you acquired it through your lifetime, which tends to be the most common type of bone marrow failure conditions. Some of you on the call may have heard aplastic anemia, which is typically described as an immune-mediated condition where your own cells, T cells, recognize stem cells and attack your bone marrow. It's a lifetime chronic illness, and you're at a little bit higher risk of leukemia from suffering from this immune-mediated disorder. Then there's a sister condition called paroxysmal nocturnal hemoglobinuria. It's a misnomer because it's not always at nighttime that you have dark urine, but that's when people have noticed it in the initial time. This is a blood disorder that's characterized by blood clots and red cell breakage or hemolysis. It frequently comes hand in hand with aplastic anemia. Then are some of the rarer disorders where just there is red cell production problem called pure red cell aplasia. There's another leukemia. For all purposes, it's classified under leukemia, but it presents with an immune-mediated bone marrow failure. For short, it's called TLGL, or large granular lymphocytic leukemia. Myelodysplastic syndrome, and there are several different overlapping syndromes for MDS. The acronym for myelodysplastic syndrome is one of the most commoner conditions for bone marrow failure, where the cancer stem cells that you have in your body are unable to make mature cells. They either die in that process or there is a cancerous cell that's inhibiting that process. So these are the different kinds of acquired bone marrow failure diagnosis that you may hear or one of your friends may be suffering from. There is a subgroup called inherited bone marrow failures. This is something typically identified in a pediatric population. So this is something they're born with. So it's called germline condition. Some of the classic diagnoses that are associated with bone marrow failure include Fanconi anemia, DBA or Diamond-Blackfan anemia, TAR syndrome or thrombocytopenia absent red eye syndrome, DKC, SBDS. These are some of the germline conditions that you may heard of some of the families suffer from that present with low blood counts and a low cellularity in their bone marrow. More and more disorders are being identified with mutations in all of these genes that I've mentioned. There's a unique entity that presents with low platelets caused by these three genes called RUNX1, ANKD2, and ETV6. They all present with low counts, and on further workup, they are identified to have this specific type of inherited bone marrow failure that typically tends to present a little bit into the adulthood, especially this one called DDX41. And all of these genes have unique stories, the way they present, the way people live with it, and the risk of having a blood cancer, having had some of these genes. It's a whole conversation and presentation to focus on each of these mutations. But for this presentation, I'm going to leave it at just the diagnosis and the different types of bone marrow failure you may have heard of or suffered through. This is one of the important slides. I wanted to make sure that the audience here today, you should leave your initial appointments knowing these. What is your diagnosis of all the things that I've mentioned? Which specific type of bone marrow failure do you have? Talk to your doctor about the trusted online sources to get more information, to read up more about diagnosis, because there are several not so reliable information out there. So ask your doctor about such a source that they trust, that they're able to share with you. Thorough medication list to be reviewed. People are on medications such as heart medications that are considered blood thinners. And if your platelets are really low, it may be time to consider either decreasing the dose or stopping such a medication. So how your diagnosis impacts your overall health condition, besides just the condition, we have to make sure the rest of your health has been paid attention to as well. So ensure that all the medications, talk to your doctor, and that they're still safe to take for your family member. Have a good phone number. This is the most important one. Have a good phone number because you don't always remember the right questions to ask in your initial appointment. So have a good phone number to reach back and what's a good time to reach back and all that. How do I handle if I run a fever? A lot of bone marrow failure patients have low immune system or a low platelet count. What if I run fever overnight? Where do I call? Where do I go? How do I handle that situation? What if I start to bleed? What is an emergency plan? 24/7 ER or urgent care that wherever your doctor is, how do they handle such a situation? Ask if you need a second opinion. Do not shy away from asking that question. Every doctor should encourage second opinion. Sometimes you badly want a second opinion and another person to look at, but they depending on the severity of your disease, there is not enough time for it at times. At the time, one way to handle is, can you just make sure you run this by your colleagues, a senior doctor, or anything like that would be helpful. You just want to make sure multiple people are paying attention to your case and ensuring that the treatment path being suggested is accurate for you and agreeable for you. Bone marrow failure condition, besides just managing the condition, there's a lot of supportive care that goes into it. Unlike any other disease or cancer story that you have heard of, where the person goes in once a month, does the blood test, gets his treatment, comes back, the rest of the month goes by with few changes in lifestyle. Blood cancers or bone marrow failure conditions do not work like that. Because there is an important organ in your body that's not making a life-sustaining blood level for you. To people, it's critical. Besides managing the bone marrow failure condition, there is supportive care being offered. So you may need transfusions to make you feel better and prevent complications from anemia. When you're getting blood, if you're in a smaller center, a discussion around what type of blood product that's being given is critical. What we recommend for most patients, especially if there is a stem cell in your future plant, a type of blood product called leukoreduced and irradiated blood product is what is needed. If you're considered at risk of infection, have a conversation about antibiotic prophylaxis if it's appropriate for you. If you're experiencing bony pain, talk to doctor which over-the-counter medicines are appropriate for you, because sometimes over-the-counter medicines may not be the right things for you, especially if your platelet counts is lower. These are some of the common questions I get for supportive care. Can my family member donate blood for me? They can donate blood, but it's best used for other patients. Directed donation towards you is risky for a family member because of some similarities in the genetic background. There's a risk complication called graft versus host disease. So you should encourage your family member to donate, but the bag can go to anybody. And the other common question I get is, we donated or saved our son's blood. Can it be used for a bone marrow transplant for my wife or husband or spouse? There's another type of question. The answer is, again, donate your cord blood. If you want to store it. It comes at a cost. But again, it's no guarantee that that's ever going to be a full match to your person. Typically, it ends up being used by somebody else. So as a good Samaritan, you're allowed to donate such cord blood, but I've never come across a case where that was used for stem cell donation for a family member. When people are asking about donating for bone marrow, there is something called bone marrow drives or marches that tend to happen. Encourage your family members to sign up to be National Marrow into the National Marrow Donor Program. That's a great thing to do. It can be overwhelming learning about blood disorders or bone marrow failure. So make notes. Take down the names of the genetic tests that are being mentioned to you. It's a lot of medical and scientific terminology, so it's okay to ask the doctor to repeat. Establish a new appointment if it's overwhelming, to break down the information for you one more time. Blood cancers are complex, so maintain a good calendar. It is key to acknowledge that it is complex And to get yourself organized around it, along with the help of your team, is critical to successfully managing a patient with bone marrow failure condition. This is one of my, I feel like an important slide that I need to present. What questions do you get if this is your first time having somebody go through a bone marrow failure condition? You may or may not be prepared. This might help some of you ask the right question. Is there a stage or a risk group that my condition falls into? Is my family at risk of developing this condition? Is this inheritable? Do I need treatment? How long can I wait to be treated? If I do require treatment, when will I feel better? Will it always work for me or not? What are some of the complications that are short-term or long-term I need to be aware of? What about food, diet, sports, and exercise? What does survivorship look like? That could be a question for later, but these are some of the questions that can help you have a conversation or help understand your condition a little bit better. So staging for blood cancers are not, or bone marrow failure conditions are not necessarily staged like solid tumors because blood's everywhere. Bone marrow is in all our long bones, but there are certain classifications and risk groups that we apply for some of the disorders I had mentioned earlier. For aplastic anemia, there's a criteria called Kamita criteria where we divide the patients into whether they have a severe or a very severe disease or a moderate disease. PNH can be called hemolytic, non-hemolytic, but knowing your clone size is critical for PNH patients. MDS, there's a classification system called International Prognostic Scoring System. That's the beginning of the conversation after you've been diagnosed with MDS. MDS, what's your risk category? And then the treatment conversation follows that. There are other myeloid cancers that fall into the umbrella of MDS and related disorders. They should typically have a disease-specific risk calculator as well. So make sure you ask that question and understand your risk category. Do I need treatment or how long can I wait? Question. Not always. Some of the conditions such as low-grade MDS or moderate aplastic anemia, if your blood counts are not too low, sometimes all you need is a transfusion or a prophylactic antibiotic. You can just be expectantly managed. Your blood counts watched very closely. Sometimes this situation can be anxiety-provoking too, even though your disease is not severe enough to be treated. Just waiting for it to happen, whether it may or may not happen. Those are the questions you could ask your doctor. Expectant management could be the right option for you. And I do acknowledge that sometimes not doing much could be anxiety-provoking as well. This is one of the important things I wanted to relate to do today, is if you are diagnosed with a treatable condition and you need treatment, it's good not to wait too long. Get started as soon as you can. Delay might lead to more complications from your disease. If it's aplastic anemia, we know ongoing immune attacks damages more and more stem cells. If you're at risk of blood clots if your PNH clone continues to grow, and all of a sudden there could be a blood clot. So not to wait too long is another important message I wanted to give you all today if you do require treatment. What to expect from treatments? This is the most critical question. You have to set up expectations from each treatment that you're signing up for. Is this treatment supposed to prolong my life? Is this a curable condition? Or is this just maintaining my condition? The intent of treatment and what's the success rate are important. And it's okay for the doctor to be honest. Sometimes the answers may not be what we want to hear, but to set up your expectations ahead of time with the hopeful lets you plan your life around it. On an average, any blood disorder, whether it's aplastic anemia, MDS, I always tell my patients, imagine how long it takes a broken bone to fix back to a normal phase that you can walk or use your hand. It takes months. Bone marrow is much more complicated than the strength of a bone. So it takes months before you see any change to your blood counts. On an average, I tell my patients to close their eyes and not to watch their blood counts for 3 to 4 months for any of bone marrow failure conditions. And how could you recognize that you're responding? Your reduction in transfusions is the one thing you may notice. You may need a repeat bone marrow biopsy to say the cancer burden or the blast percentage is lower. So your blood counts are slowly normalizing. They're not quite normal, but the transfusions are going on. So these are the different kinds of ways one can tell that your condition is improving or not improving. But frequently seeing doctors doing labs becomes part of your family's routine. Remember, for any response conversation, any survival conversation, the numbers are like a bell-shaped curve. Your story could be on this end of the spectrum, right in the middle, or when doctors express numbers to you, they're telling you on an average in the middle. Your story could be better than that or could be worse than that. So have that knowledge around the conversation or the numbers that your physician might be telling you. When you get started on treatment, how do you manage your condition? Go on to MyChart, make sure you have your online appointments, make sure you have filed your after visit summary so you know when to go back to. Have the medication box filled by either a pharmacist or if you have a very savvy partner, have them. So because to remember to take all the medication is key, compliance is key to a successful outcome. If there is flu season or something happening, discuss what's a safe time to get vaccines. Living will and healthcare proxy or difficult conversations, but it's always good for your family members to know ahead of time. Should something happen through this journey, what are your living wishes? So that's another conversation you need to have with your family member. And you also advocate for your family member going through the treatments. If they're suffering for something, they don't hold back, they express it. And when they express it, they're adequately heard by the team, or another place you could strongly advocate for your family member. Take down a list of complications during consenting for a treatment. Usually they mention side effects. Write down some of the important side effects, what to watch for. Discuss visitation policy with your family member. Managing your family becomes a whole thing during this illness. Do not love any sick ones. You love them, but you just love them from a distance while they're ill. So have that very clearly stated to a lot of your family members. To lower your risk of infections, some of the things that I let my patients know: if your immune system is severely compromised, pet birds and cats are discouraged because they're high risk of transmitting certain infections. Yard work, cleaning up vents, getting rid of mold in the basement, these are heavily discouraged. This is asking for trouble. If you're attending an indoor gathering during flu season, if possible, wear a mask. Supportive vaccines, extra air filters are always good. Learn about as needed medications. What should I do if we develop a fever? What should I do if we feel nauseous? What should I do if the pain's not controlled? What is the definition of a fever? If he's on steroids or she's on steroids, some of the things, these are something family members should be aware of. Nutrition, since you're juggling your work, your family member with illness, people tend to, applies to both the patient and caregiver, keep up with your nutrition, accept help with meals when somebody's helping with meals. Education regarding sanitation needs, like we cannot eat anything that's been sitting on the counter. For freshly cooked meals are always preferred, so on and so forth. So do not hold back from having such an open conversation. Some of the common things, is it safe to exercise? Fatigue is a big thing. You may want to avoid intense exercising, but exercising at a slow pace, aerobic exercising is encouraged with any of the bone marrow failure conditions. Preventing infections is the biggest supportive care you could do. How you handle a newborn child is how you should handle anybody with bone marrow failure. Washing hands frequently, regular dental care to prevent tooth or gum infections, things like that. Healthy, balanced diet. If there was a diet that magically made things disappear, I would be eating it regularly. So lots of veggies. There's nothing like that. So healthy balanced diet is key, but making sure you're getting your calories in a good way is the most important. Freshly cooked food is always more important than stale food and getting into trouble with that. Emotional health, I cannot emphasize the amount of burden the patient might be feeling, that they're troubling their own family and not being a contributing member. Caregiver who is giving in so much to the patient, they could be a caregiver burden too. So being knowledgeable of this, doing small things that make you happy and seeking help for that would be critical. If your condition warrants transplant now or in future, make sure you complete looking for a bone marrow donor workup, have a caregiver plan for it, continue to work to maintain your muscle strength, be on high alert for fever, rashes, anything that concerns you that you should let your doctor know. It is a lifetime journey if you do go through bone marrow transplant, but there is a time where you'll enter survivorship and taking care of your heart and things like that will become priority at that time. Just a few points on disease-specific things. If you do have this condition called acquired aplastic anemia, please do not delay therapy. I've mentioned this before. There could be more stem cell damage. Treatment is age-dependent. I've mentioned some of the things that are critical to talk to your doctors. Not all the medicines that are given to a child are appropriate to an adult, such as L-Thrombopag. It is a lifetime journey. Surveillance is key. Once you're being treated with aplastic anemia, you're still at a little bit of high risk for blood cancers and PNH. So you continue to follow with your doctors after that. PNH families, the advice for you is not everybody needs treatment. The treatment decision is critical because it's a lifetime therapy and there's a financial toxicity to it. The good thing with it is there's a lot of new medications on the horizon, so do discuss with your doctors. Let your doctors know if you're dealing with any infections. If you're on treatment and you're dealing with any infections, you may need extra therapy for the inhibitor that you're taking. Compliance is key. Please do not miss any medications because that will cause worsen hemolysis. Keep up with vaccines. That's another key element for PNH patients. MDS families. MDS is very heterogeneous. Your story could be very different from anybody else. Know your risk category. Discuss if clinical trials are an option for you. Note that hemoglobin threshold is different for each person, but most institutions have cut it down that if you're only less than 7 grams per deciliter, because of limited blood pool through pandemic time, we have learned that this is a safe zone to transfuse patients. Talk about genetics if more than one family member has this condition, or if you're age less than 50 when you're diagnosed with MDS, you have to know if this is an inheritable condition, so ask your doctors those questions. There is lots of new options if you're suffering with anemia and you have MDS, and know your erythropoietin levels and what subtype of MDS you have. If you're on a group of medicines together called or referred to as hypomethylating agents, your dose could look different if you have low-grade MDS or high-grade MDS. So you could have a conversation with your doctor about this. Discussing prophylactic antibiotics if you're on chemo is critical, or if you are frequently getting infected. This is another frequently overlooked thing while you're getting treatment. There's a whole group of conditions the bone marrow failure patients are dealing with. These are lots of patients are being diagnosed with changes in their DNA called mutations seen in their blood while their blood counts are normal or they have a normal marrow. This phenomenon is called clonal hematopoiesis of indeterminate potential. We think it's an aging phenomenon. There's slightly higher risk of blood cancers. It's a whole conversation in itself. If you're diagnosed with this, again, just find the specialist, not just a regular community hematology oncologist. Go to a blood doctor that focuses on clonal hematopoiesis to discuss if you need surveillance or not. Finally, advocate for your family member suffering for blood and blood cancers because it can be a very lonely and emotional process. Be a helping hand during healing time. When you enter the survivorship phase, be a helping hand and offer help for somebody else who's beginning this journey. Encourage your family members and neighbors to sign up for marrow donors, because we need more donors in the pool. Thank you all so much, and God bless everyone. I'm happy to take questions.
Oops. Thank you so much, Dr. Thota, for the very informative presentation for caregivers. So we do have a few questions. Our first question is, what is the IPSSM calculator?
That's a great question. So International Prognostic Scoring System, this refers to if anybody that has MDS as their diagnosis. There are 3 different calculators, and they have evolved over time. The original one is called IPSS. Then there is a revised IPSS, which focuses a little bit more on your blood counts and DNA changes and the blast percentage. There is a more recent calculator. It's a novel update in the last couple of years for patients suffering with MDS called IPSSM molecular, where I had mentioned some of the genetic changes that occur. They are included for the first time. The good thing about this calculator is it's dynamic. So if you're diagnosed this year with MDS and you have a certain risk category, you can fall into one of 6 categories. It may be looking different in 3 years or 5 years. And if you do undergo bone marrow biopsy, then your IPSSM risk score changes at that time. So it's kind of a scan for your MDS diagnosis to say, am I continuing to be in low risk, or did I move up to intermediate or high? Did my risk score change? So it's one of the most recent one. I would hope people are widely adopting it. I definitely use it for a lot of transplant decisions in my patient population that I was unable to do before the advent of this tool. There's an online, I'm sure on AMDS website, you'll find a link to the IPSSM calculator.
Thank you.
It's present in NCCN guidelines as well. Thank you.
Great. Thank you. We have the question says, my mom is getting an injection to raise her hemoglobin. If the number is at 10, she will not receive an injection. How does this correlate with the 11.5 you gave for women?
Yeah, it's a fantastic question. It's the unfortunate truth of insurance dictating some of the care for our patients. We typically, when we use these agents, either erythropoietin or luspatercept, any of these medications that we are using to boost the hemoglobin levels, we try not to shoot over 11 grams per deciliter. There is certain data. Some of these agents are used in a separate group of patients called chronic kidney disease patients. They have studies to stop at 10 hemoglobin in that. You could shoot up to 11 too. Trying to hold of beyond 11 should not be done because the risk of blood clots go up. What is measured as 10 this morning could be measured as 10.5 tonight. I think it's okay to be in between the 10 and 11, especially if you feel better. It's actually one of the pet peeves of a lot of MDS doctors that some of the insurance dictates this 10 level based on kidney literature. I hope that answered your question.
Thank you, Dr. Thota. Our next question is, how likely is it for a patient with low risk MDS to develop acute leukemia?
That's a great question. Again, so overall, as a group, MDS, we quote like only 1/3 of them transform to leukemia. This is all MDS is putting together. As a generic group, I also mentioned it's a heterogeneous group. So if you have low-grade MDS, let's pretend it's SF3B1 mutant MDS. It's one of the most indolent type of MDS. Your lifetime risk of changing to acute leukemia is really, really low. The IPSSM calculator that I had mentioned is one of the ways we communicate this to our patients. So I hope you can find that link online and plug in your hemoglobin, platelets, some of the bone marrow findings and genes in there. And it spits out a number about your risk of transformation to leukemia in 1 year, 5 years, and a percentage. So it's low. So not everybody transforms to acute leukemia, but IPSSM is the best way to answer that question. Thank you.
Thank you. Our next question says, my family member was diagnosed with aplastic anemia, and they are still currently taking cyclosporine. How do you know when the best time is to discontinue the cyclosporine? Is there a weaning process we should be asking about?
Yeah. Fantastic questions. I love all the questions today. I had it up on my slide for a little bit, but did not delve too much time into it. That's a very important question. And there has been some change in thought process. I hope this is an adult patient that you're talking about. So the last time point we wait for ATG to show its full effect is at 12 months. You see responses are as early as 4 months, 6 months, but 12 months is the last time point you wait to see if ATG worked or not. Now, if you had responded, all your numbers need, if they completely normalize, it's called a complete remission. If you don't achieve normal levels, but you're transfusion independent, you're called partial responder. The answer is very clear in complete responders. When you have normal blood counts at month 12, the rule is you start tapering. I taper by 20%. There is no rules to this. People say taper. My way of doing it, which is a widely adapted strategy for a lot of people, is to go down by 20% every 4 to 6 weeks and see if it's impacting any of the blood count changes. So I do monitor the blood counts very closely, but cyclosporin can be tapered starting a year. People have noticed that if they started tapering, they are seeing some early relapses. There is an addendum to one of the NIH protocols to extend cyclosporin among adults to a longer duration for an additional 6 months. And some practices, especially if you see that everybody should try to taper, if there is concern for an early relapse, go back on cyclosporin to rescue your blood counts is one way to rescue from an early relapse. So you do see sometimes, based on case-specific details, that people might stay on longer than 12 months, but most people should start once they've achieved their best response to try and go down on cyclosporin levels. Among adults, it's not uncommon that you see that people are stuck with tiny doses of cyclosporin, like 50 milligrams or 75 milligrams twice daily, subtherapeutic levels. But on doing tapering multiple times, we have identified that you just need that amount of cyclosporin to maintain your blood counts. If we go any lower, blood counts are falling down. So there is a small subset of patients that tend to stay longer, but the rule is to try and taper starting 12 months onwards.
Thank you, Dr. Thota. Our next question is, my spouse has had what his team calls a partial response to ATG cyclosporine eltrombopag treatment. What's the difference between a partial response and a complete response?
Great question. I'm glad that they are responding to treatment. Complete response, your neutrophils have to be greater than 1500 per microliter and maintain that level. Hemoglobin has to be above 11.5 grams per deciliter in the normal range, and platelets have to be a 3-digit number, typically in the hundreds, 150s. That's called a complete response. Some people do a bone marrow biopsy to make sure the hypocellularity resolved as well, but that's not part of the criteria. If you do not achieve these levels, but you have not received transfusion in the last 6 months, your hemoglobin's ranging anywhere between 9 and 11. Your platelets are not quite 200. They are like 99, 55 in that range. You're transfusion independent, but your numbers are not fully normal. That's what is referred to as partial response.
Thank you for that. Our next question says, my husband's neutrophils are 0.2. Should he be taking extra precautions?
That's a great question. Sometimes those 200 cells are the mightiest cells that you have. I've definitely had a lot of patients whose neutrophils are 0.2, 0.5, never really ran into trouble. And I have seen people with normal values and drop their neutrophils and get into trouble. So being cautious is always a good thing. So what does that mean to be cautious? Some of the things are common sense stuff like washing hands and not just eating any food that's on like free samples at Costco or something that they're just handling, knowing where your food originates, discussing if prophylactic antibiotics are appropriate for you, especially for viral and fungal infections. The duration of how long you have had the 0.2 is critical to make some of those prophylactic medications. People talk about in dietary changes, something called neutropenic diet. It's not heavily data-driven, a little bit more common sense-driven. They say eating peeled fruits is better. So do you really need to avoid berries? I think washing berries heavily and then consuming it is okay. But freshly made food, knowing your food source origin, making sure that it's still fresh. Those are some of the things. Discussing prophylactic antibiotics is a good thing. And like frequent hand washing, I cannot emphasize how critical that it is to help. Mass is another thing that you could consider during high viral seasons, especially for a large indoor gathering.
Thank you. Our next question, and it looks like this is our last question here, is my wife tends to get mouth sores and overgrown gums. Is there anything that can be used to help with the mouth soreness?
It's one of the tough ones. I appreciate the question. So it is unclear to me because the gum soreness could be from using cyclosporin long term. It is key to identify the cause of mouth sores and the gum hyperplasia. It seems to me from the story that somebody has a bone marrow failure with low neutrophils and on some sort of medication that's making their gums sensitive, which is a common thing that tends to happen. Warm liquids, first thing. Second thing I talk about is magic mouthwash. A lot of people use Swish and Spit. It has Maalox, lidocaine, Benadryl, a little bit of anti-inflammatory and soothing the pain. That's what they use. Warm liquids are like I have already mentioned. And one home-based trick that you can use is actually rinsing your mouth frequently with baking soda and warm water. So mouth rinses can be another thing. Avoiding spicy food is another good thing to do, and extremely hot food to avoid worsening. Sometimes, especially in MDS, if this is an MDS patient, that's an issue. Temporary relief can be obtained by using growth factors too. So the different ways to cope with it. It's a hard symptom to live with. Appreciate the question.
Well, thank you so much, Dr. Thota, for sharing your time and your expertise with all of us today. This webinar will be available to watch again at a later time on our website. For those watching, you will receive an email from us letting you know when it's available on the website for you to be able to watch. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. This concludes our webinar. Thank you, Dr. Thota.
Thank you all. Appreciate it.
Have a good night.